Monoclonal antibodies are transforming the way we treat multiple myeloma as new agents that we can combine with many other drugs safely and effectively with very impressive results. There are now 2 monoclonal antibodies approved for use, elotuzumab, which targets the cell surface marker SLAMF7, and daratumumab, which targets the cell surface marker CD38. Both have been shown in phase 3 clinical testing to combine very well both with proteasome inhibitors and with immune modulator drugs such as lenalidomide or even pomalidomide. Our experience clinically has been very positive for both agents. Elotuzumab, perhaps a drug better suited for slower progressing disease, perhaps patients who are more elderly because of the frequency and duration of infusions and the side effect profile. Daratumumab is proving to be a highly effective drug across the spectrum of treatments from first relapse through end-stage disease. It is a drug which is quite safe to give and can combine easily and probably has some of the best reported results yet in multiple myeloma in the relapse setting. As with most monoclonal antibodies, infusion reactions can occur. Particularly notable perhaps with the drug daratumumab are some upper respiratory tract side effects, including wheezing, running nose, running eyes that do require some attention. For both monoclonal antibodies that we use, daratumumab and elotuzumab, pre-medication is recommended. This is usually a combination, as described in the package insert, of a corticosteroid, either solumedrol or dexamethasone, both an H1 and an H2 blocker such as Benadryl and cetrizine as examples, and sometimes acetaminophen is also added to that combination. Today, both these monoclonal antibodies are given intravenously. Daratumumab, particularly during the first infusion, can take most of the day. It can take anywhere from 6 to 8 hours sometimes to deliver because it needs to be started slowly and the dose slowly titrated upwards. Elotuzumab can be given over a shorter period of time and is given every 2 weeks instead of every 1 week. After the first infusion of either drug, with subsequent infusions, particularly with daratumumab, the infusion time will generally become shorter as long as the patient has not experienced toxicities or infusion-related reactions. It's important to note that most of the reactions with daratumumab, as an example, occur with the first infusion in up to 40% of patients, but generally do not recur with subsequent infusions. So it's really the first infusion that is slower. One requires a little bit more caution and attention. Beyond that, it becomes relatively easy to use and the infusions are definitely shorter. Practical recommendations for the infusion, which can take the entire day, is certainly to bring the patient in early in the morning and get started early so they can finish before the unit closes in the evening. This is obviously reasonable if your infusion unit is open for long enough. In some instances, patients have had to be admitted overnight to hospital if the infusion unit closes early. But generally speaking, we've found that we can get the infusion in, particularly the first week, within a working day if the patient starts early.